All right. Thank you guys for coming. Welcome, everyone. This is our shoulder instability live stream, of course, brought to you by ProArm and the team here. But before we dive into today's session, I'd like to take a moment to discuss some important guidelines and etiquette to ensure this discussion is productive and respectful as possible. So first and foremost, we're all here to learn, share, and grow professionally. So with that spirit in mind, we ask you remain courteous and supportive in your interactions with the speakers and with the fellow attendees. Regarding the structure of today's session, we'll start with a lecture and a refresher for some of you on shoulder instability, followed by an in-depth discussion on diagnosis, treatment approaches, and outcomes. We want to try to really touch on our treatment styles and treatment approaches and share with you some of the things we've learned and some of the mistakes we've learned even. So we encourage you guys to be active live participants here. So if there's a question or comment that you want to shout out, go ahead and type into the chat. We'll have one of our team members working the chat. And so just clearly state the question or comment if you have one. And if it's directed at a particular panelist, just make sure you put the name in. And we're hoping to have an insightful discussion here. So lastly, we just want to remind everyone that this is a learning opportunity. And so regardless of one's experience level, there's no bad questions. I know early in my career, I wish I had a forum or a place that I could have bounced some ideas off of people. And with this type of outlet here, live streaming ever since, of course, COVID, and everyone's going digital, it's really we're really embracing, not just national but international collaboration with other providers. So I think it brings a lot of value. So as a special offer too for being here tonight, we're going to be discounting our premier course, which is hosted by Terrence Segroy. It's called the Rotator Cuff Decoded. Usually it's $250. It's going to be down to $99. Promo code CUFF99. It's over 60% savings. And it's good till tomorrow night, midnight. So without further ado, let's get into it. I'm going to start sharing my screen here. Again, if you have questions, go for it. And we will make sure we get those answered. So sharing screen. Let's get this pulled up here, guys. And just let me know if you're having trouble seeing it, and we'll go from there. And sharing in 3, 2, 1. All right. Can you guys see the screen?
Yep, we're good.
All right, perfect. Thank you guys again. So this is shoulder instability. I'm your host today. I've always wanted to say that. I'm your host. My name is Russell Linville. I'm a sports physical therapist practicing out of Minnesota. My practice is largely upper extremity. I see a lot of postoperative upper extremity. This is a topic that's near and dear to me. While I've never suffered a dislocation of my own shoulder, thankfully, I've had friends and former teammates that have, and I've always wondered about this injury. And then as I became a PT, I took a deep dive into shoulder, and really, it's really one of the most fun things that I treat is post injury and post operative shoulder dislocation. So we'll go over some of the highlights here. So the objectives, I just want to apply the principles of arthrokinematics to the glenohumeral joint and understanding various directions of shoulder instability, compare and contrast classification of shoulder instability, including the mechanism of injury, age, gender, and recurrence rates, demonstrating safe and proper techniques on a partner, maybe take this into your clinic and go ahead and work on a coworker or someone. If you haven't practiced these tests in a while, we'll go over some of the special tests, and then select and apply interventions for a plan of care appropriate for shoulder instability.
Hey Russ, do me a favor. Could you just put in presenter mode, and if we don't see your screens or your slides advancing?
Oh yeah, absolutely, man. Yeah, let's do this. Yeah, thank you. See, always having some technical difficulties. So from beginning slideshow, let's see if this works. Not in presenter mode yet. Let's see.
Yeah.
Classic.
Right there.
Right there. All right, here we go. If I advance, can you see now?
No, it didn't take up the full screen.
All right, let's see if I can figure this out. It wouldn't be a Zoom meeting without a technical difficulty, would it? Let's see here. Monitor. Use presenter view. See if this is checked here. Let's see if we uncheck that. What happens? Anything here?
No, but when you scrolled down before, we saw it. So You.
Down here?
So when you moved your cursor before, it moved down on the slides. But I don't know if you want to just click one down.
Yeah, I can just slide through like this.
Yeah.
Yep.
That'll work.
Better? Perfect.
Yep. All right. Fair enough. So let's try to maximize this then. Let's see if we can get this going. All right. So here I am. This was a picture you were supposed to see earlier. This is me. You can find me at these different contact areas, of course. So here are our objectives. And then here is our outline of what we want to do today. So we're looking at introduction, define our terms, and look at the mobility spectrum, as we call it. Then in terms of classification, we're going to look at direction, etiology, degree, frequency, and volition. If you haven't heard of volition before, then we'll of course talk about that. Talk about some things with examination, evaluation, and of course intervention, which I think is why most people are here. So we have to define our terms. So what is instability? Well, instability, just by the Webster's definition, is the quality or state of being unstable, of course, and the lack of stability or firmness. It's also the tendency to behave in an unpredictable, changeable, or erratic manner. And so that's different than what we might consider to be laxity. Laxity of a joint is the state or quality of being lax or loose. And so it's normal to have individuals who are on a mobility spectrum. And so one example of that is this gentleman here, Michael Phelps. We might not call him unstable. We would call him lax, right? His tissues are genetic, has a predisposition to tissue elasticity or extensibility. You can see his elbow extension, range of motion there, and of course his shoulder motion as well. So this is defined by having no pain, and it could include genetic disorders such as Marfan syndrome or Ehlers-Danlos syndrome, and very common for these individuals to have high Beighton scores or Beighton index. And so this is something that during our exam we want to make sure of. Is this person actually unstable, or are they lax and having maybe some multi-directional instability that's leading to pain? And so I think it's important to understand our patient's body types pretty quickly. So instability then is defined as painful laxity or hypermobility. You can see the picture on the right. This individual suffered an anterior shoulder dislocation. That's a classic hallmark sign of that. You can see the sulcus sign. And if I move my cursor or mouse over, the sulcus sign here. And let's see, let's make it bigger. And you can see the sulcus sign. That's a hallmark, of course, that the humerus is not in the right spot. So it causes, of course, there's three causes. It could be caused by poor dynamic stability in people with genetic laxity. This is going to be like your multi-directional instability. We call these born loose individuals. It could be caused by repetitive overuse, like in overhead athletes. We might call this worn loose. And then it could be caused by a traumatic incident. And this is like your motor vehicle accidents, your FOOSH. This is your shoulder dislocations in football games, hockey games. These are sudden force into extreme ranges of motion. This would be your torn loose. So born loose, worn loose, and torn loose is how I try to remember it. And so hopefully that's something you can take away from this as well. Here's another example, the visual example here. You have your born loose people on the very left. These also might be congenital in nature. We think of these as maybe individuals that are under the classification of AMBRE. If you go back to PT school and try to remember these terms, AMBRE stands for atraumatic, multidirectional, bilateral, rehab, and then I think inferior capsular shift would be surgery to fix that. Then you have your repetitive stresses to the labrum. Of course, that might be something like a slap tear or capsular redundancy in someone who throws a lot. That'd be a worn loose. And then a TUBS, traumatic unilateral Bankart may require surgery. That'd be a torn loose. And here's another individual. Unfortunately, this looks like a younger individual with that shoulder dislocation. So stability and mobility, I think of this as a sliding scale. And so if you look at this picture here, you'll notice that we go from rigid all the way on the left side of the screen all the way to hypermobile on the right. And what we try to do is create a green zone. This is the happy medium that you want your patient to live in. You need a good base of stability and mobility to have a happy shoulder joint. And so when we get the patient on one extreme or the other, we're really thinking that these might be where injuries occur. And so hypermobile, obviously we were here talking about shoulder instability. So that's an injury that can occur with a very hypermobile shoulder. If you guys want to participate, you can put into the chat, what do you think would be type of injury maybe someone with a very rigid or stiff shoulder might have? Would it be, what type of differential diagnosis would you be thinking there? Obviously, hypermobile, we're thinking instability. What's the opposite? Just a food for thought if you want to throw that into the chat. As we move on here, here's a great video, and I had this I had this synced up so that the ball would fall off of the tee. So what I want you to do is try to imagine that's happening. And unfortunately, with my slideshow not working how I wanted it to, some of the animations I have are going to be not as funny as I originally thought they might be. So anyways, picture that ball falling off the tee, and maybe I can even do this, drag it away. Okay, good. We've heard this analogy a million times. The ball and socket joint is like a golf ball and a golf tee, and I don't think that's quite right, but for purposes of comedy, maybe we can do it here. It's inherently unstable. There's not very much bony congruency. We need both inert and dynamic stabilizers, and so if we move on, this is an example of that. These are our inert stabilizers, and highlighted in yellow, you'll see the labrum. And the picture on the left, I want you to appreciate here is the joint capsule that's been incised and reflected back. So you can see kind of this robust connective tissue that also helps stabilize the glenohumeral joint. And then you'll see up here, there's muscles, of course, those are muscles, the rotator cuff. And then if we look at this from more of a a sagittal plane view, you'll see the labrums here. You can see the biceps tendon coming off the top. And you can see some of the glenohumeral ligaments involved in the big joint capsule. So it's all incorporated as almost one continuous unit that allows for inert stability of the shoulder. So just wanted to make sure we looked at some anatomy pictures there. Here's some other pictures of the capsule that's not incised and reflected. So you can see this actually looks like a pretty stable and airtight type of container, if you will, for the shoulder. And then some of the muscles, the supraspinatus, subscapularis, and things like that are helping reinforce the stability of the shoulder. If we move on again to some other pictures, of course, this is more in the same. The capsule is actually, you can see, is pretty robust and large. It's got a large surface area. Of course, it surrounds the entire shoulder. Here are the muscles that sit on top of the joint capsule, and this is what really adds that dynamic stability. The main role of the rotator cuff is for co-contraction. So when all these muscles fire simultaneously, it adds compressive forces to the humerus, which keeps the ball centered, for lack of a better term, within the joint and provides stability. So when people have a shoulder dislocation, for instance, and they have their inert stability is compromised, we really need this the dynamic stabilizers to work in overdrive to really provide the stability once again. This should be a flashback for you to PT school. We're thinking about different types of motor control and different muscle balances here. So as the force couple is the word I'm looking for. So as we move our arm into abduction, you're going to get a roll and a glide in the humerus. If we're looking at true abduction, you're going to get a superior roll and an inferior glide. Well, how does the ball stay centered in the socket? Well, you're going to get compressive forces from the cuff and then also supraspinatus, keeping that ball centered. So the deltoid becomes a primary mover. Here's another example of that co-contraction from the rotator cuff. The anterior and posterior rotator cuff provides stability to the joint. And then you also get the deltoid, which is going to be your elevator as well. Here's just some other pictures, more anatomical pictures. Some people learn better with schematics rather than the actual anatomy. So here's what this looks like on the glenoid side, and then here's the humeral side. And if we look at this, we think of, and one of the ways that you'll learn about some of these injuries in terms of types of tissue damage is we think about the face of the glenoid as a clock face. And so what we do is we go from 12 o'clock all the way, down to 6 at the bottom, of course. And when we look here, if we were to look at this as being a right shoulder, you can see in the red portion here, that's going to be from your 3 to 6 o'clock. That's going to be your anterior to antero-inferior quadrant, if you will. That's going to be more where anterior shoulder dislocations or anterior labral issues are. The yellow section is going to be more where the posterior issues are. And then your slap tears are going to be more in that 10 to 2 o'clock range. So when we define, these injuries, it's important to understand where in the actual anatomy and the glenoid and the labrum this injury is occurring, because it will drive your rehab. So when we think here about classification, a couple things we want to do here is figure out the direction, the etiology, the degree, the frequency, and the volition. We talked about this a little bit earlier. For shoulder instability, we have a couple different ones, right? You have anterior, of course, we've kind of harped on that so far, posterior instability, inferior instability, which is not very common. We're genetic, we're generally all pretty lax inferiorly, or then multi-directional, which of course, as the name implies, you're going to have at least two of these present at one time. So it might be an anterior and an inferior, or an anterior and a posterior, but multi-directional is a classification as well. Etiology, you want to think about this traumatic versus atraumatic. Degree, obviously, we've had people that have done everything from dislocate their shoulder, which would be the most severe, to just subluxing their shoulder, which maybe it gets to the end of the rim of the glenoid and then has a spontaneous reduction before fully dislocating. And then, of course, we want to make sure people, and clinicians especially, understand what apprehension is. So you may have an event which is not quite a subluxation, but takes your arm into a position that you were not comfortable with, and then you have a fear avoidance of those positions following. Then frequency, we want to figure out if this is going to be acute, if it's recurrent, or if it's a chronic injury. And then volition, can this individual that we're treating voluntarily dislocate their shoulder, sublux their shoulder? And we've all known people like that, and we'll have a picture of that, what that looks like later. So anterior instability, it's proposed that 90% of cases of shoulder instability is in the anterior direction. Of course, this occurs with excessive anteroinferior translation of the humeral head. Really, the mechanism of injury is a traumatic incident, maybe with an outstretched arm, maybe with a fall, but it's going to be in that hyperabduction, horizontal abduction, hyperextension, external rotation positioning. So kind of up in that, almost like a thrower's position, landing on the arm in that direction. It may cause bony injury due to trauma associated with the dislocation. We call those bony Bankart injuries. That's going to be an anterior inferior glenoid rim fracture, which is caused by the shoulder obviously the humerus dislocating and hitting the rim of the glenoid. And then you might also have what's called a Hill-Sachs lesion, which as the humerus dislocates, you have all those inert and dynamic stabilizers trying to keep the ball centered still. And so what happens is you get this, your body tries to reduce the dislocation, and the posterior side of the humerus hits the rim of the glenoid, thus causing either a Bankart injury or this depression fracture in the posterior humerus, which is your Hill-Sachs lesion. So I remember always getting those mixed up early on, and so I think it just takes a little time to memorize those. Posterior instability, it's allegedly 1 to 5% of the cases. I think I have a specific practice where I see, my caseload is probably, out of all instabilities, probably about 25% is posterior. So maybe my caseload's a little biased here, but allegedly 1 to 5% in the literature. Usually this is traumatic or repetitive overuse. Can be caused by forceful axial loading of the upper extremity. So we're thinking people like linemen who are blocking, who are taking a lot of axial load through the arm, power lifters such as bench pressing, falling on an outstretched arm. And really one of the special tests we do for this, right, is a posteriorly directed force through the long axis of the arm in internal rotation and cross-body adduction. So those 3 planes of movement can help reproduce this pain on exam. Multi-directional instability, again, at least 2 directions of instability. Inferior instability, we might see they have a positive sulcus sign, which is when we traction the arm, you'll get that sulcus, as we looked at the picture earlier of that. This is usually atraumatic. It's with repetitive overuse, can be caused by microinstability of the capsule as well. So what about superior instability? Well, we don't usually see true superior shoulder instability, and this is due to the anatomy. Of course, you have the acromion that sits as the roof of the shoulder joint, and so we're not going to really dislocate superiorly, but we will wear that tissue down, and usually that occurs in the form of slap lesions. So a couple different ways we can do that. One is with a peel back mechanism, which I encourage you guys to review that. The other is with traction type injuries, such as decelerating the arm during throwing, repetitive throwing. So we'll have a lecture series in the future regarding throwing injuries and at which times during the biomechanical position of the arm do certain injuries occur to help you guys differentially diagnose injuries. And so this is something we go into great detail in that lecture series coming up. So when we think about this, the arthrokinematic considerations, we talked about this a little bit earlier, and anterior instability, you want to be cautious with external rotation. It's obviously most risky up at 90 degrees of abduction, extension, horizontal abduction, and especially combination of these movements. Just think, if you guys picture the anatomical position, right? And you think about the planes of movement, you have the sagittal, the frontal, and the transverse planes. Anything that's going, taking your shoulder and your arm behind the frontal plane or behind the coronal plane is risk of anterior glide of the humerus in the socket, right? So we're getting a posterior roll, anterior glide in these positions, and that's how you can try to remember this. So this might drive your exercise interventions as well. This is why we don't do bench press and stuff early on in these cases, because as the arm comes behind the body under load, we're creating this shear force that might reproduce this type of injury. Posterior instability, of course, is going to be the opposite. So we're looking at internal rotation, hyperflexion, flexion with axial loading, of course, and then maybe upper extremity weight-bearing positions early on are going to be things we want to be cautious of because of the arthrokinematic considerations here. I'm a visual learner. I like having little charts like this. This helps me figure it out. We talked about Ambry tubs and repetitive overuse stuff yesterday, but this is kind of how I try to differentially diagnose it in the clinic. Someone comes in and they have, they're meeting the demographic that I might consider shoulder instability for. I'm trying to put them into these buckets to help me figure out and drive the treatment approach that I might do with them. So, of course, subjective history is huge in this population. We're really trying to figure out why they're here, where their pain came from, and then we can start to fill in the gaps, of course. So, just a different visual for you. The degree, again, dislocation, subluxation, or apprehension. Of course, we can see what a dislocation is here. Thankfully, we don't have to respond to a tremendous amount of these. You know, we have our great colleagues, athletic trainers, and our physicians who are on the field who may have to actually reduce these. We're not really allowed to reduce these. Move that out of the way so you can see a little bit. We're not allowed to reduce these, as far as I know, in Minnesota in our Practice Act. So when we cover sporting events, we have our great athletic trainers and MDs that help us. Subluxation, of course, is a shifting of the humerus on the glenoid, a near dislocation. And you can also have what's called a spontaneous reduction, which whether you sublux or you dislocate, without someone helping you, right, a medical provider helping reduce your shoulder, sometimes the shoulder will reduce on its own. And that's usually people who have recurrent issues here. And of course, apprehension. So once you've subluxed or dislocated your shoulder and you have stretched out the inert stabilizers, you may have apprehension to movement. And this is why we have that apprehension test to see if people have fear, avoidance of putting their arm in certain positions where anterior glide or shear is occurring. So acute, you know, we talk about frequency. Is this acute? We want to make sure, and this will drive our treatment approach. If it's an acute injury, we're going to treat it like an acute injury. If it's recurrent, we need to know where they're at in their recurrence rates. Are they a serial dislocator? If they are, they may have soft tissue insufficiency outside of the labrum and capsule. And really, you know, I'm thinking here of individuals that are over 40 years old. It's uncommon for them to dislocate their shoulder in the first place because they don't engage in contact sports very much, and they're not doing risky behaviors very much, you know, 40 and older. So to have recurrent issues at that age, other things may be going on. But especially in these people over 40, we're concerned of rotator cuff injuries, especially. And then chronic. So history of shoulder instability with no recent events, but they may have in the past 2, 3, 10 years ago had a shoulder dislocation. It's important to understand if someone's having current shoulder pain to ask about history of shoulder issues, including dislocations, because you want to understand that anatomy as best as you can. Here's a picture down at the bottom of someone volitionally subluxing their humerus. And so as you can see, they're creating an inferior glide by just contracting, I'm assuming they're packing their lat to create this shear force down, as you can see here. So voluntary subluxation is an example here. And then involuntary, this is when it gets really bad. If you have a lot of bone loss of the glenoid or tissue redundancy, you're going to have times when your muscles are relaxed, like such as sleeping, where you might have involuntary shoulder subluxation or dislocation. And one patient I saw had, they said they had 20 something dislocations, and what forced them into surgery was that they woke up every morning, their shoulder was dislocated. And so after about, a couple of weeks of that, they were like, I guess I got to get this looked at, because they had to reduce their shoulder every morning when they woke up. So it's crazy. What about examination? Well, we're going to do the same thing we do for almost every patient here, obviously. Talk about the initial injury, their pain, where the location and intensity is. Did they need medical management for this on the field? Was it reduced? What was their neurovascular status? Obviously, when we have an anterior dislocation, we're concerned about things like the brachial plexus and thoracic outlet type of issues. So are they still dealing with any transient numbness, tingling, anything like that? What's their past medical history? Do they have connective tissue disorders? And then we're trying to get their current symptoms. And we, at the school I work at, we call this SINS. So severity, irritability, what's the nature and stage, and stability. Are their symptoms improving, worsening, or are they not changing? And so we're trying to get an idea of the stability of their current condition. And of course, we do goal setting, patient preference, clinical experience, and current literature all are the tenets of evidence-based practice. So we try to form those in our decision making. So observing the patient, of course, your med screening, we mentioned connective tissue disorders quite frequently, the Beighton score. There's also a 5-item questionnaire for historical hypermobility. These are questions that you might ask your patient that are like, has anyone ever told you you're double jointed? Has anyone ever said, or have you ever dislocated your shoulder in the past? There's other tests outside of the Beighton score that you can use, and not just your shoulder dislocating, but if someone's dislocated kneecap or something like that, then that might give you clues of what their body tissue type is. And then if they have scars, you can look at their scars. Do they have keloid scars that might indicate that they lay down scar tissue thicker, or do they have stretched out scars from years ago where it's really looks like that skin has been stretched, and that might give you some idea of their tissue extensibility. And then you can just do like a Turgor test, as most of you can do kind of on your knuckle, right? You can pinch the skin on your knuckle and lift up. Does Josh, you want to do that? And you can kind of lift up the skin on your knuckle, and if someone has a lot of excess skin that you can drag up, they might have increased tissue elasticity as well. So as we move on, here's the Beighton score, and so you guys can look this up as well. But this is a series of 5 different tests that you score from 0 to 9. You grade all of these bilateral, so this would be 1 or 2 points for each of these, and then 1 point for palms to ground touch. So if someone's meeting more than 4 or more, I should say, what we're going to do is classify them as someone who's maybe genetically a little more lax or hypermobile. And so I encourage you guys to do these tests on yourself now and see where you're at. So if someone's meeting that high score, this is kind of usually my reaction. They're going to be way over here. And then my eyes raise and go, oh shoot, we got some work to do. So as we continue on here, exam test, of course, during active range of motion, we're going to look to see if they're guarded or apprehensive to movement. Do they have a side-to-side difference with range of motion, and are they presenting with any dyskinesia? And so I know it's a hot button topic, is scapular dyskinesis. Does it exist? I think in the case of shoulder dislocation, when any side of the whether it's the glenoid or the humeral side is affected, we're going to get dyskinesia at the shoulder. So we just need to assess and see why maybe that's occurring. Passive range of motion, obviously you want to be gentle in precarious positions based on the arthrokinematics we discussed earlier. Of course, you want to get the measurements so you can track this over time. Patients are really discouraged early on at their range of motion loss, and so it's a good way to track that. With strength testing, we look at resisted isometrics. We call those RIMS, or manual muscle testing, but really we try to get dynamometry involved so we can get some clear objective measurements. And then really, I really have to stress this neurovascular check. There's not many people ask about this, and it's interesting to see, in the first week to 3 weeks, how many people have this, what I would call transient numbness in areas they didn't even know. So doing things like dermatome testing, I think, is important as well. here's some special tests, and you guys back in PT or AT school, I'm sure learned these ad nauseum. So just some things to think about and practice maybe. But your anterior instability test, the big one is your apprehension and relocation test you can see here. So you get them up in the external rotate position. This is how we do it at the facility I work at, is with the apprehension test, we actually provide an anterior glide to start with. And so then we reduce it as the the relocation test. So we encourage a little bit of anterior slide first, then externally rotate the arm. And if that's apprehensive, then we reduce it and see if the symptoms have changed. So something to consider here. Caution with this, obviously. If this is a recurrent dislocator, any anterior glide or a load and shift may cause a subluxation event at minimum, and maybe a dislocation at maximum. So cautious here, and just go really slow. But obviously, they'll tell you right away if they hate this, and just get out of it. Don't force the issue on some of these individuals. So here's an example of the radiographs we talked about earlier with the Bankart, bony Bankart. See the fracture of the rim of the glenoid here, and then the impaction fracture in the back of the humerus. That would be your Hill-Sachs lesion. CT scan would give you a much more detailed view, and a CT scan would be used for things like surgical planning. Same with an MRI. To see if different procedures need to be done, which we won't go into detail about those procedures much unless you guys want to in the chat after this. So what about intervention? I think this is a 5-phase pyramid, essentially. This is how my brain tries to classify these, and really most injuries as well. But really, when we talking about getting people back to return to sport, phase 1 is going to be tissue protection, range of motion. Obviously, your acute injuries here, we're going to make sure we really protect that tissue and gradually expose them to more stress within their comfort range. Phase 2, we think of this as muscular endurance, rhythmic stabilization, beginner strength training. And then we move on to phase 3, progressive strengthening, stability, and motor control, into phase 4, which would be more of your plyometrics and advanced training. And then phase 5, we're doing things that are similar to their sport. And so we'll get into another slide here in just a minute or two that goes over some of my suggestions for exercise interventions. So what do we do in terms of immobilization? As you can see, this is a football player who's landing on an outstretched arm. They're going to, as their body weight takes them down, you can see how they might go into a hyper horizontal abducted, externally rotated position. And this is, what's his name? Earl Thomas. So he has a history of shoulder dislocations. And this was a play he dislocated his shoulder on. So what do we do afterwards? Do we wear a sling or do we not? Any ideas? Well, my slide gives it away. It depends on the symptoms. Obviously, it depends on the individual. If you have someone who's very scared, apprehensive, maybe it's a young athlete that is his first time or her first time dealing with an injury, we might wear a sling to give them a sense of psychological comfort and make sure that we're reinforcing, that everything's going to be okay and that we're doing something for them. But in someone who's a little older, that we can explain this to, that maybe he's not as fear avoidant, we may not use a sling. And we may use a sling for 1 day, 3 days, 7 days, 2 weeks. It's really dependent on the individual. There's nothing suggesting, right, if it's a dislocation that's been reduced, there's nothing suggesting that they need a sling unless they're having a lot of involuntary instability, I would say. And those patients probably will need surgery at that point. Here's what some different types of return to play bracing looks like, options for return to sport. The top left, you have this, it's called your Sully brace. You guys have probably seen this before. You can wear this underneath, obviously, your pads or your garments. This right here is called a Duke wire brace, a little more intense, obviously. You have your Sawa brace. I've never seen anyone use this. This is like a medieval corset, for shoulder stability. I can see hockey players maybe wearing this and things because it's kind of rugged, but really how much of a pain is that to get on and off? And this is something you see a lot now is your Breg bracing. You see these under shoulder pads, and if we look at this individual here, you can see that's what this person has. So under the shoulder pads, they have this, which is what this strap is for, obviously, on the arm. So if you see football players in particular wear this a lot, defensive backs, running backs wear that. So you'll know that individual may have sustained shoulder instability before. So if we move on to what I consider to be the big 4 of exercise programming, we're not going into the nuances of the individual exercise. We'll have those posted on our content online as the weeks progress here. But there's 4 big key things here: rotator cuff strengthening, periscapular strengthening, advanced proprioceptive training to get co-contraction of the cuff, of course, and then what I consider to be core strengthening. So I'm thinking from shoulder down to waist, how am I strengthening the large muscle groups of the shoulder to add compressive dynamic support? Here's what that sort of looks like here. So rotator cuff strengthening, I think of that as strengthening the rotator cuff in general. Internal rotators in particular, I'm interested in because if you think about the position in which a shoulder is dislocated, going posterior, to the coronal plane, we need muscles, strong muscles, to keep it from going in that direction. So internal rotators, pecs, things like that are going to be important to prevent this injury from happening. So scapular strengthening, of course, creating an environment for a stable base of support for the cuff to work on. Just an example, this is maybe your prone scapular exercises. When we think of advanced proprioceptive training, of course, rhythmic stabilization drills, perturbation training. Don't forget about closed chain exercise, great co-contraction of the cuff on EMG studies here. Progress from stable to unstable surfaces, plyometrics when appropriate, and then core strengthening again. Primary movers, spinal stability work. This is just getting you more robust as a human and harder to get injured. So I want to thank you guys very much for being here. I'm going to stop sharing the screen now. We'll pass it on to other members of the team with questions, or anyone in the chat that has questions. Thank you very much. I also must say thank you to. I'm back here. Thank you too for the technical difficulties early on, and dealing with that. So appreciate your time with that. So.
Russ, it's great talk. As anyone on this call, if you have questions, put them in the chat and we can get to them. But so I've got a question for you. Recently we had a big shoulder dislocation on the Knicks, and how would you manage? So you have someone coming into the end of the season, possibly playoff run, first time dislocator. How would you manage that basketball athlete?
Yeah, I mean, I think we'd have to get them on the table and see what their apprehension was like. Are they fearful? If they're not fearful, then I'm thinking of going straight to something like a Sully brace right away. We'll get them on the court. Obviously not in competition. We'll get them on the court. We'll see what their dribbling looks like. We'll see, put them in some dynamic movement situations if they feel comfortable. These individuals are not going to be weak. So when we get on the table, we're not going to see that they have weakness like we might expect maybe in a younger player who dislocates. They may have loss of range of motion. I'm trying to consider, is this their shooting arm? Is this their non-shooting arm? Are they, when they drive to the hole, are they driving and using one arm in particular? Like, is a part of their game going to be in jeopardy, so to speak, if we put them back out there? And so that's the thing. Those are the things initially that I'm looking at when assessing return to play right away.
Yeah.
There's some studies out of West Point, and the return to, so these are cadets that have shoulder dislocations, and the return to activity is anywhere from like 1 day to like 2 years. So there's high variability in when you return to sports, and so I think it depends on the patient. So.
And we know in these younger athletes that the rate of recurrence of shoulder dislocation is very high, right? So what is your thought process, either one of you, when someone is a first-time dislocator, they're young, so say they're 23 years old, probably high chance that they're going to re-dislocate. Are you going to opt for them to have a surgical consult, or are we going to rehab this first?
Josh, you want to take this one?
Yeah, I think you have to go the rehab route, for sure. I think, you talk about this in the context of your athletes where there are timetables for certain things. I think that becomes a little bit more challenging as far as some like quicker guidelines that you have to go through. I think if you have somebody that has the time, I would go down the rehab route first and allow this thing to scar down and give it the appropriate time to load appropriately, and also know the demands that this person has to get back to. Whereas I think those are some of the challenges, and kind of what was posed in the chat a little bit too, is like different considerations based off of, what the demands are for that individual.
Yeah. And timing would come into play too, right? So you're nearing playoffs. If it does redislocate, they're going to have surgery anyway. So what are what's the risk of trying to rehab it versus someone that might be, early off season and you want to get it fixed to make sure they're back for next year, right? So I think timing considerations for the athletes definitely important as well.
Yeah, I'll just say to Terrence, the sport I get most concerned about with these and getting them back quick is wrestling. And wrestling is obviously, it's a combat sport. Your arms in positions that are, your opponent's literally trying to manipulate your body outside of your free will. Those are individuals really hard. Those are such tough athletes. Psychologically, they're so tough. Physically, they're so tough. It's hard to hold them out, and sometimes you can't. Football players, we can really strap them in with that sully as best as we can, and that gives me, as a provider, a little bit of uh, I guess, solace in knowing that we're doing something a little extra. Wrestlers, you can't wear that stuff. You can't. It's like, so I get scared with the wrestlers, but
I think that highlights though what you kind of said before, Russ, too, and what we're kind of talking about a little bit in the chat is like, there is a distraction type for some of this stuff, and then there's a compressive type for these different injuries, and your wrestlers end up being in those positions where they have some of both, where they might get their arm pulled on, they might end up being in a bad position, or they might be, loaded posteriorly too, just depending on what type of injury. So they could have both going on within the course of a match, which makes it probably the most challenging. So,
yeah, absolutely.
Thomas's question. So what are the main considerations? What are your main rehab considerations when you are working with your overhead athletes versus your, contact athletes that are not necessarily overhead?
Well, let's be honest. This is a really tough injury to, if we're thinking anterior instability, let's say you have a football player that dislocates his shoulder in the fall and he wants to get ready over the winter and he's a pitcher on this high school baseball team as well, or his college, whatever, his high school, college baseball team. And it's his throwing side. These are extremely tough to rehab in that time frame, and maybe in the course of their whole career. If you have inert tissue laxity and you're trying to throw a ball violently, those two things don't add up. You have to have extremely strong cuff, and even then, it might not be enough. And then the surgical option there is even worse outcomes. If you get an anterior stabilization procedure or a slap repair or something on a throwing shoulder, now you're talking at least 9 months probably of rehab, and then even then might not have enough range of motion to get back to throwing, especially with the velocity that you want. So the outcomes are pretty poor. I would see if they, can we get them back to their position? What position do they play outside of pitching? Are they a DH? Is it, if they're a right-handed thrower, is it their right hand that they're, are they right-handed batter, left-handed batter? Those are things that I want to know because that'll tell me where their arm is in space during their sport. Just pass it on to you, Josh, because you work with a lot of obviously baseball players. What are you considering with throwing athletes and the considerations here?
Yeah, luckily enough, I think you guys can probably chime in too. Like, haven't seen as many slap repairs, thankfully, in the last couple of years. I'm kind of glad we're going away from that. But I think one of the most challenging post-op shoulder injuries to rehab is anterior stabilizations in your throwing athletes. The job of that surgery is to limit somewhat the amount of motion and provide stability in that abducted and externally rotated position, that unless you kind of fit that mold of also being very hyper mobile, it's very challenging to get external rotation range of motion back, which tells you the surgery was probably a success. But then there's a lot of compensations that have to happen to try and achieve that. Getting thoracic extension, guys start leading with their elbow. It's probably one of the more challenging injuries that I've seen in baseball pitchers. Just it takes a very long time to try and regain range of motion that the surgery is restricting. So,
yeah, I think to that point, I've got two right now that have had anterior stabilization, and I think what we don't really they go through their long toss program. They're at 120 feet, 135. They feel okay. And then they start getting some intent behind it. And for me, I think what I didn't really pay enough attention to was more the horizontal abduction, right? So I feel like they can get back external rotation, but when you combine, when the body takes them back into that horizontal abduction that our players get into because they're generally loose, that's when they start to feel some of those symptoms. And I mean, I mean, looking back and reflecting, I don't think I stretch them enough in those positions because I've focused so much on restoring external rotation, being mildly aggressive with that early on. Because if they don't get that back, then nothing's going to work. But I think if you really look at the positions of their bodies, it's getting back the horizontal abduction with external rotation, which some guys definitely have trouble with, and it's tricky. I mean, once those sutures go in, they tighten up. Like Josh, to your point, the purpose of the surgery is to stabilize the shoulder, hold the ball in the socket, and we're trying to have them do these movements again, these positions that are just not natural for the body at the speeds and these intensities that we've never seen before. So it's a difficult case.
Yeah, I think it's some of these too. Just like one last point on that is like, like you get these general timelines, but if you have a skilled, athlete that has to have, demands around their shoulder, like throwing, like those timelines tend to shift because there is going to be a certain amount of time to allow this to quote unquote stretch out to allow them to achieve those positions that you're talking about, Terrence.
Yeah.
Yeah. When do you stretch them?
When
do you stretch them into horizontal abduction? Do you ever feel comfortable doing that?
Yeah, around 12 weeks.
And you mean you're saying post-operatively?
Mm-hmm.
Yeah, I think it depends a little bit on the hypermobility of that individual. I think you have to protect those that are a little bit more hypermobile because you don't want to stretch out a repair early. The ones that are a little bit tighter that are fairly stable. It's still probably within that same time range, but I definitely am doing other things around that to make sure that we are not getting too stiff that it's going to be a big challenge on the back end to get them some of their mobility back.
Yeah, and I feel like I've also never really had to stretch, like truly stretch somebody. I think that early stabilization does a lot for them. So isometrics early, just centering the humeral head and the glenoid really regains a lot of their motion. And then just some soft tissue work around the shoulder, like as they come back. I think pec minor sometimes becomes an issue, and that'll limit horizontal abduction. But if I truly thought they were tight and need to be stretched, I'd be comfortable doing around 12 weeks.
We gotta think too that you're going to if you're already sitting in an anteriorly and superiorly directed position, like from being tightened up following surgery, you're already going to have some restrictions then getting into external rotation and horizontal adduction, or abduction. So I think those are some considerations, like you said, Terrence, like trying to get them to be in a better centered position so that we have some abilities to get into those ranges rather than kind of already being at our end range.
I'm going to share this quick. This is I've thought about this topic a lot of horizontal abduction. This is how I measure it at work here. If this is the position people have to get into, how do we measure that? And so I use the table to stabilize, and then we drop the elbow off just in this neutral rotational plane. I don't know if we should drop into external rotation. Should we start here, measure this angle right from the acromion down, and maybe they have some videos of himself throwing or something previously. Can we get that? Can we get that angle back? And what is the angle? There's not much literature at all. There actually, I don't think is any on the importance of that or how much we need to get back. So I think it's a good point to bring up. We got some other questions in here. Let's see here. Some of you guys have answered some of the questions in the chat, but Rich, let me just read through your question here. Rich, how much external rotation range do you typically see after anterior stabilization procedures? I have a current patient who is 6+ months out who has about 75 degrees of external rotation before crazy apprehension occurs. However, surgeon says that that's all the motion that he wants him to have. He also struggles with abduction and horizontal abduction range of motion. And so since I read the question, I'll go ahead and answer my take and then pass it on to Terrence, who sees a lot of these post-operatively too. 75 degrees, and I'm assuming you're measuring it kind of in this supine position, rotating the arm back. 75 degrees, I'm not too worried about that range at 6 months, unless they're a thrower. That range isn't bothering me too much. I wonder if your apprehension question there, you said 75 degrees before crazy apprehension, or if you mean that it's painful, right? It feels stiff. It doesn't want to go. He's getting some impingement type symptoms. Usually we feel that posterior type of impingement from capsular tightening procedures. So if it's that, then that's different than apprehension. If it's apprehension and they feel like the shoulder's slipping out, then I don't know if that surgery's been successful, obviously. But if it's more pain or discomfort, I would expect them to be stiff. Now, if they're stiff also in abduction, horizontal abduction, obviously the horizontal abduction kind of goes hand in hand with that procedure. We're tightening everything up in the front so we can't get backwards, we can't rotate backwards. But this individual may have a medically induced frozen shoulder, so to speak, where they've lost capsular mobility on purpose to provide inert tissue stability. And so what I do is I right away look at internal rotation range of motion. Can we get any internal rotation range back, even through sleeper stretch? I know there's debate on sleeper. I mean, I do sleeper stretch quite often on these individuals if they have global range loss. How are we looking on lat mobility and flexibility? What are they looking like on posterior inferior, joint mobilizations, things like that? We're going to get hopefully obligate translation of the humerus within the socket with some of those techniques that maybe our external rotation is going to improve by working on the other planes of motion. So maybe we're getting some neural tone down regulation with some of those techniques that allow you to get overhead or get externally rotated a little bit more. So that's kind of where I would start in a case like that. What do you think, Terrence?
Yeah, I mean, I don't mind the 75 degrees. I'd prefer them pretty closer. I mean, we'll take ours close to 80, 85. But I don't like the apprehension. So if they're 75 degrees, I'd expect them to be tight and so comfortably tight. But if they're apprehensive, I would have similar concerns. I think maybe, potentially there's some issue structurally happening there, or maybe they just need, increased isometric. Something like this, I would do heavy isometrics. So I would try and center the humeral head in the socket. Long duration isometrics, 30 plus seconds at moderate resistance, just comfortable positions to try and really have them feel that stabilization around the shoulder, see if that improves range of motion. I mean, if they're not getting back to an overhead sport, I prefer them tight than loose. But I don't like the apprehension. So if it is pain or apprehension, yeah, I mean, I guess it would be case by case. And then also the type of patient. So I would check their opposite side. Are they hypermobile on the other side? Because typically, like we've mentioned before, the hypermobile patients, they get their motion back on their own. So unless they were overly tightened in surgery, I mean, I'd look at the number of anchors and the procedure done. It was a remplissage, sort of become a little more trendy these days at our hospital. We've been seeing more remplissage procedures that will make them tight. And the remplissage, just very basically, you fill in the Hill sacks that you talked about with the posterior cuff, but that brings on some other issues as far as motion, but it makes them, more stable. So yeah, I would definitely have some additional questions about this patient, but I don't like the apprehension. So I'd focus on isometrics, I think.
Yeah, very good. He gets both pain, that painful posterior pain, as well as feeling like it will pop out again. Yeah, I mean, if it's that apprehension, then there's a reason he's not going further. So, you know, I'd have him consult with the surgeon if you think he's getting that 6 anchors. Nice. Is some of this how much like uh, I don't want to say muscle memory, it's the wrong term. There's some probably neurological hypersensitivity to capsular tensioning that maybe some of these people get. And that may be a little bit over even my head here. It's like if that capsule gets put on tension, is that sending a signal to the brain of fear and threat when now it's actually stiff and scarred down? So I do like the idea of isometrics, maybe just to get that individual used to those positions where they're feeling that apprehension, and have them understand that maybe you had a surgery to fix this. You haven't had any recurrent issue, meaning you didn't fall and have a big dislocation episode after surgery. So we can assume, air quotes, that the surgery has created stability in the shoulder, this might be your brain interpreting your position in space. Your proprioception's off, and so you're getting the signal of apprehension. I think maybe that's the route that you go next.
It's a tough case.
Yeah, I think we definitely probably, Rich, you look at it from a sense of like, if you perform the test similar to your anterior apprehension and you provide an AP glide, does that change what their symptoms are in that end range of their positioning? And I think one thing that we're probably all guilty of in some regards is that we do a really good job of getting people strong and stable and kind of inner and kind of mid ranges. But then there's some challenges in getting people strong in their end ranges, And so, like Terrence was saying, providing isometrics, even if there is an AP glide at the shoulder, to try and get them centered so that they're getting some co-contractions, to try and get some stability. I think I would check those couple things out to say, hey, does an AP glide, does that reduce my sensation of feeling that posterior pain and that feeling of instability? And then training within that position at 75 degrees of ER, trying to get some kind of rhythmic stability, and then starting to do some co-contractions to see if that changes their positioning and their sense kind of at that end range.
Yeah, good stuff. Any other questions we missed? I'm gonna scroll back through and just double check here. I know you guys talked about nerves and stuff earlier a little bit, and then talked about hitting as well, batters hitting. And let's see.
Just real quick on the nerves, I've seen a few axillary nerve disruptions. People have had traumatic dislocations because the nerve wraps around the humerus, and definitely something to pay attention, because if they did have nerve injury, you have to know on the rehab side, obviously the surgeons will typically wait until the nerve starts to recover, but they're going to have some additional posterior shoulder pain because of where that nerve innervates the posterior side, but also start having significant atrophy of the deltoid, which is going to limit their recovery process, as well as teres. So they're going to have some external rotational weakness from that. So just talk to your surgeons. You can never stress enough how important communication is with the surgeons as far as what was done, because an anterior stabilization is not an anterior stabilization. So there's a lot of variations.
Yeah, very good. And on that point of nerves, I probably catch 1 or 2 suprascapular nerve palsy issues a year too. So someone comes in, they had a shoulder instability event, usually a posterior, right? You get now a posterior labral tear, capsules torn. You're getting a paralabral cyst that's not been diagnosed. They come in, they're weak. They go to urgent care. They get a PT script, just shoulder weakness. They have atrophy of their infraspinatus, supraspinatus, and they can't move their arm well. It's an interesting case there, but suprascapular nerve palsy, axillary nerve palsy. So those are all associated, well-known issues that you need to check for, and unique cases, obviously.
Yep.
So
good. I think that just about wraps things up here.
Yeah, thank you guys for coming. I really appreciate your time, and again, we'll be doing more of these in the future. And the next one we'll be doing is going to be on throwing biomechanics and workload capacities. We're going to try to get that one in early June, maybe late May, early June. So be on the lookout for that. We're going to have a special guest coming in to talk about some of that as well. So appreciate you guys coming. Thank you very much.
Thanks, everybody.